Good evening, everyone. My name is Diana Beasley, Management Synergistics, Inc. I will be moderating this evening's event. I am so delighted that you've taken time from your busy schedule to join us today. All across this city and across the nation, there have been testing for HIV, and for that, we are very, very proud and extremely happy. This is National HIV Testing Day, and this is our town hall meeting. It's a joint venture with the Chicago Area HIV Service Council, known as CAIS, and Step Up and Get Tested collaboration. The Step Up, Get Tested collaboration is comprised of nearly 30 partner organizations. That includes Illinois and Chicago Department of Health, Public Health, along with Chicago area hospitals, community health centers, and community-based organizations. Our purpose this evening is threefold. Number one is to provide an opportunity for participants and our viewing audience to report on the existing HIV prevention, care, and housing services. Number two, to create a public platform to address HIV service gaps and to hear the community's strategy to address those gaps. And last but not least, number three, to meet HRSA requirements for CAIS. We want to provide an opportunity to hear from the community, and this is the best way to do it here at the Core Center. As I look over the audience, I am extremely proud and happy to see all of you that are here today participating in this, and also to know that we are live. We are being broadcast by the cable channel CAN TV 27. We're also being streamed live, cantv.org/watch. This reproduction will occur again, and CDs will be made available. We also want to encourage you, if you're watching and you have a comment, feel free to email us at chicagocais@gmail.com. Let me repeat one more time. That is Chicago CAIS, that's CAISC@gmail.com. We want to also take the opportunity to thank our sponsors. Step Up, Get Tested Coalition, Chicago Department of Public Health, CAIS, the Illinois Department of Public Health, and CAN TV. So we want to thank everyone for your participation. As we start today, we want to have an official welcome. And our official welcome from Dr. David Barker, who is the Chief Medical Officer and Acting Executive Director here at the Core. Dr. Barker?
So yes, it's my pleasure to welcome all of you to the Core Center this evening and potentially to our tornado drill. If there is a tornado, we're going to go through these doors behind you. So. And I'm only half kidding about that if you've looked outside. So. We redid a bunch of the square footage of the Core Center in the last 2 years, courtesy of the Core Foundation. And we had a rededication at the end of that, and part of the discussion was embracing the National HIV Service Plan to get to an AIDS-free generation. It's certainly something we believe is necessary. It's a shame it took so many years to get one. But throughout the health system and the thing I'm about to show you is the health system's work rather than the core center's work, because most of the testing I'm going to show you didn't occur here. But the first part of the national plan is testing. And there is no truth that I use PowerPoint at wedding toasts. I'm tempted to use PowerPoint at wedding toasts, but I refrain. So this is testing in the county health system over the last 5 years. And the blue bars on the top represent routine testing. So that's average doctors throughout our health system doing HIV testing for their patients. And what you can see is it went from very few tests in 2008 to almost all the testing in 2012. And overall, the county health system offered more than 72,000 tests last year. And one of the things we want to ask the coalition as they consider this is to reinforce success. So anyway, but welcome. Hopefully we won't have the tornado drill, but enjoy your meeting.
Thank you. Thank you, Dr. Barker, for that, for welcoming us here. We feel welcome when we walk into this facility, and we're glad that you're here. This evening, our event will take on 2 phases. The first phase is that we have a distinguished panelists here that will talk a little bit about various aspects of HIV and AIDS. I'm going to introduce them, and then we will call on them to give their brief, make a note, brief presentation, because we are conscious that we are on a time schedule and we are, of course, streaming live. So therefore, we will be asking our panelists to do just that. After that, the second part of our event this evening is to hear from you. And that is to hear from consumers, from providers, from anyone that are here to let us know around HIV and the strategies, the gaps, the services, and how they relate to prevention, testing, as well as housing and care. Those are our emphasis for this evening. So allow me to introduce our panel. To my right is Nick Brashad. Nick is the Director of Surveillance, Epidemiology, and Research for the Chicago Department of Public Health, SITI HIV Division, and formerly the Director of HIV Behavior Surveillance Unit. We want to thank you, Nick, for being a part of our panel.
Thank you.
Next, we have Ms. Marisol Gonzalez, Director of Prevention and Education here at the Corps. Yay! Marisol, of course, manages multiple testing and linkage to care programs with Cook County system, and currently she is leading the HAT, H-A-T program, which is designed to fully integrate routine screening and at multiple sites across the county system. Thank you, Marisol, for being a part. Mr. Peter McLeod, Chair of CAHIS. Peter is the community co-chair at the Urban Coalition of HIV Prevention Services, community co-chair for CAHIS, and consumer development and advocacy coordinator here at the Corps. Thank you so very much for being a part of our panel. Daniel Pohl. Daniel is the director of HIV SITI prevention at Howard Brown Health Center. Daniel is also chair of Prevention and Early Detection Committee of CAHIS, and we thank you for being a part of our panel. Mr. London Benton, got it, an HIV activist. As an HIV advocate, activist, and professional singer, we may get a song, who knows? London served on the Chicago Area HIV Planning Council and is featured in the Get Real, Get Care public service announcements. Thank you so much for being a part of the panel. Dr. Toyin, I'm going to call her Dr. Toyin. That's what her certainly beloved patients call her. And of course, she is an HIV hepatitis specialist, researcher, attending physician in the Cook County Health and Hospital System, also hepatitis clinic director. She is authored and co-authored over 40 manuscripts published in peer-reviewed journals and has presented over 50 abstracts, particularly at conferences both national and international. Dr. Toya knows her. Our next panelist, Mr. Mark Sellers. Mark is the Public Health Administrator for the Chicago Department of Public Health. Mark manages the city programs that provide housing, assistance, and related supportive services for people living with HIV throughout the EMA. We thank you for being a part. And Ramon Gartenshire. Ramon is the Director of Government Relations at the AIDS Foundation of Chicago. Ramon is a tireless public advocate for people living with and or at risk for HIV. We thank you so much for being a part. So now, we will have the opportunity to hear from our panelists. Of course, they will be coming and talking with us around their level of expertise. We're going to start off with Nick, and he will talk with us regarding, of course, the epi data. And of course, we have Marisol, who will be talking about linkage and diagnosis to care and retention. And for those that, go, linkage to care? What is that? It really means getting involved in your health, getting tested, understanding what it means to link to care, to stay in care. So both Marisol as well as Peter will be talking around that. We're going to ask Daniel to, of course, highlight risk and infection. We're going to also be asking our doctor to talk about various issues as it relates medically and viral suppression. From that perspective, we're going to be asking Mark to talk about housing and essential services and the services we need for people to stay in care. And of course, we will be asking Ramon to give us a legal perspective, the advocacy perspective, as we work around this. And London, of course, will be coming and talking with us regarding a youth perspective. So it is my privilege and my pleasure. If you've not given them a round of applause, guess what? Do it right now. And we're going to turn the microphone over to Nick.
Thanks, Diana, and very happy to be here today with the group. I'm going to talk to you briefly, and I have not been known to be brief, so this will be a little bit of a challenge. To talk to you, give you a brief overview of the HIV epidemic in what we call the eligible metropolitan area. So Chicago, as well as the 9 counties that surround Cook County, including Cook County. So just as an overview, we estimate that there are about 34,000 persons living with HIV or AIDS in the Chicago area. In 2011, we saw about 1,400 people newly diagnosed with HIV in the Chicago EMA. Now, considering that historically, over the last decade, we've seen that number drop from about 2,300. So we've seen about a 40% decrease overall in new HIV diagnoses across a decade, and 20% decrease in HIV diagnoses across the last 5 years. So needless to say, we've made a lot of progress. Our efforts have made a big difference in the amount of HIV that is being transmitted and acquired in the Chicago area. Some of the reductions are really actually quite dramatic. If you think about female diagnoses, they're down about 50% across the decade. Among injection drug users, they're down almost 80% across the decade, which is, a sort of unheard of. When we talk about HIV elimination, this is a group that we look to for guidance in how to eliminate the epidemic. And importantly, there's been no decrease among the group that carries the largest burden of HIV infections, which are men who have sex with men, or MSM. In fact, when you look closely at trends in that group, you see that there has been a decrease among white MSM. There's been about a 53% decrease in new HIV diagnoses among white MSM. But at the same time, during the same period, there's been about a 30% increase in HIV diagnoses among African American MSM. And there's been no increase or decrease among Latino MSM in that same time period. So really what we're left with is one of the keys to describing the epidemic in terms of its racial disparities. We now see today, we see double the number of infections among black MSM than we do among white or Latino MSM. The racial disparities among women are even more stark. Although we've seen new diagnoses go down among women in every race category, still there are 10 times more HIV diagnoses among black women than there are among white or Latina women. So, this is the disparity that we really use to describe the epidemic in the Chicago area. So one of the tools that's been, you might have heard of, that's been really recently been adapted very widely to sort of try to track and monitor where we're going with ending the epidemic is a tool called the Cascade. So the Cascade sort of describes the continuum of care, or the stages of engagement of care. The idea being that new research has shown that if we can get everybody with HIV on medications, virally suppressed, we can eliminate 96% of new infections, which will virtually eliminate the epidemic. But that's sort of easier said than done. This Cascade, it's a great visual tool that identifies the specific stage of engagement that people are having trouble reaching. That may be being diagnosed with HIV, may mean being linked to care, being retained in care, being virally suppressed. So the 34,000 people who are living with HIV, we know that about 50% of them are receiving consistent HIV medical care. And we know that less than 40% of them in the Chicago area are actually virally suppressed. So if we're going to make this cascade actually a plateau, we need to bring those numbers up quite a bit. We have a long way to go. And testing is, the first step. So, we know that about 18% of people who have HIV don't know that they have HIV, and that number actually may be higher among young people. More recent CDC data is showing us that there's more, the number may be higher than 18% among younger individuals. And we also know from data in Chicago that less than half of IDU and heterosexuals are getting tested regularly for HIV, and among MSM, the most affected group, the testing rate is only about 2/3 are reaching that annual rate of HIV testing that the public health establishment recommends. So we have seen a lot of progress. We still have to maintain our vigilance in terms of the same barriers we had to changing people's behaviors are the same barriers we're going to encounter in trying to get people through the cascade and engaged in care. So I will now turn it over to Marisol, who will go in depth on some of these other indicators. So thank you.
Thank you. Good evening, muy buenas tardes. Thank you for the opportunity to talk with you about HIV prevention y gracias por la oportunidad de hablarles sobre la prevención del VIH. I will do this mostly in English because I only have 3 minutes. Today is National HIV Testing Day, a day to raise awareness, increase one's knowledge of their own HIV status. Knowing whether you are HIV positive or negative gives you the power to take ownership of your own health. If you're negative, how to stay negative. If you're positive, get in care, take care of the illness, and not the illness take care of you. As Dr. Barker mentioned, there is a push by the CDC to make HIV testing part of your medical care. So when the provider checks to see if you have anemia or how your cholesterol is doing or if you're diabetic, he will also order an HIV test. This can happen when you come through Stroger's emergency room, which he talked about, any of the Cook County clinics and the Core Center. If you test positive, we have programs to help you link to care and stay in care, which I'll talk a little bit more about in my 2.5 minutes. High impact HIV prevention is the CDC's approach to reduce HIV infections in the United States in response to the President's National HIV/AIDS strategy. That starts with testing, to diagnosing, to linking, to staying in care, and getting on medications. Proven HIV interventions, of course, are HIV testing and linking in care, medications, antiretroviral therapy, and we already know that the earlier you get diagnosed and the earlier you get on treatment, your chances of passing on the virus are dramatically reduced. Access to condoms and sterile syringes. Prevention programs for people living with HIV, such as partner services, prevention partnership for health models, and healthy relationships. Partnership for health and healthy relationships are CDC models of prevention that are either group level or individual level interventions. People who are at risk for high risk for HIV infections, such as sex workers and injection drug users, substance abuse treatments, of course, and screening and treating for sexually transmitted infections is also a way of lowering your risk of getting HIV. And there's also pre-exposure prophylaxis. So let's talk about some of these, interventions. As Dr. Barker stated, we have significantly increased the number of HIV tests through the Cook County Health and Hospital systems. Some of the things to consider when implementing this is who will follow up on the patient who is positive and how. That is definitely one of the first questions we get asked when we talk about doing this routinely. Well, who's going to check on this patient? And how do I talk to the woman in front of me who looks like my grandmother? Well, guess what? People in their 70s and well further into other years are having sex with Cialis and thanks to Viagra also. To address this, we have implemented a linkage to care manager, outreach, and partner services. Through these programs, we have been able to link 72% of our patients from the emergency department and 89% from the screening clinic within 90 days of their diagnosis. Okay? Thank you. From a HRSA a project of national significance for women of color, we have linked 84% of women into HIV primary care within 60 days of diagnosis. That is using a peer patient navigator model. Retention in care and antiretroviral therapy are key. We at CORE believe in consumer empowerment and have adopted a peer patient navigator model. Well, I want you to know that once connected to care, we will connect you to the ancillary services, especially case management, mental health, and CD as needed. I just want to end, because my time is up, with get tested, whether it's with your doctor, through the emergency room, TPAN, Vida Sida, Howard Brown, or CORE. Get tested, know your status, and if you're positive, know that you are not alone, and that we have services for you, that with medications you can live and live strong. Gracias. Thank you.
Thank you, Marisol, and thank you all for taking the time to come out tonight. I want to speak about this issue from a very personal perspective. Prior to the the wonderful work that you're seeing within the Cook County Health and Hospital systems and the efforts we made through this collaborative over the last month. Going back to 1995, I was a long-term IV drug user, so I exist in that population that Nick referenced when he was speaking, people who we've made significant progress in terms of reducing the amount of infections in that population. I was 18 years old when I started using heroin, and I used heroin off and on up until 1997. Till the time I was 43. So that was a significant part of my life. I have no doubt that during those years when I was using drugs and sharing syringes with my friends and peers who were also getting high, that was when I acquired HIV. In 1995, I started having some significant health issues. I presented in an emergency room a couple of times on the South Side and was told that I had bronchitis and sent home. In 1996, I presented at another emergency room hospital on the South Side 2 different times and I was told that I had thrush. This time the emergency room doctor told me that thrush was an indication of HIV infection and told me that I should go get tested. Later on that year, I appeared in another emergency room after being very ill with jaundice in my eyes. My eyes were completely yellow and was told I had hepatitis and sent home without treatment and told that there was no treatment for hepatitis at that time. So that was 5 opportunities over those 2 years where hopefully today a person presenting like that, and each one, I want to tell you that each time I presented in emergency rooms, I told the doctors about my drug using history and the fact that I was currently using and addicted to drugs and was never offered an HIV test. Sadly, even today, with the advances that we see in HIV testing within the system, our efforts to do community-based testing in the community, we still see too many people coming into emergency departments, finding out they're HIV positive late in the disease. They're having what is called a concurrent HIV/AIDS diagnosis, which is what I had when I was finally tested in 1997. I was hospitalized right away at Cook County. I was very fortunate that during that 8-day stay at the hospital, a number of people in the Cook County Hospital HIV primary care program visited me on the wards, told me about the services that were available, and effectively linked me to care. What was important is that not only was I linked to medical services, but that was the opportunity for me to really get support for my addiction, to see a mental health counselor, to be introduced to a case manager because I was homeless. So this idea of testing, linkage, and retention and care is critical not only for a person who's HIV positive and getting medical services, but oftentimes that's the first opportunity that that person has, people who can support him on the other myriad of issues that they face. So I'm extremely grateful and completely committed to this disease and supporting other people living with HIV and reducing disparities because of my own personal story. Thank you.
Thank you, Peter. Good evening, everyone. My name is Daniel Pohl. I'm not going to speak too long because really when I heard about this event, I got really excited because I thought it might be an opportunity to hear from some of you about ideas that you might have about what we should be doing better or what we should be doing differently or more of. And so I look forward to that tonight. So be thinking a little bit about what feedback you want to give us and what questions you want to ask us. But I will say a little bit about myself. I started at Howard Brown Health Center, and I'm proud to work there since 2001. Howard Brown Health Center is the Midwest's largest lesbian, gay, bisexual, and transgender health organization, along with the Broadway Youth Center. And when I started, almost 12 years ago, I did not know that this would become my life's work. But at this point, almost 35, it seems to be where I'm going to be. And I'm proud about that. So my background is in prevention, testing, and partner services. So when we talk about prevention, how can we keep uninfected people HIV negative? Whether it be with condoms and other safer sex supplies, behavioral and risk reduction interventions, information and awareness, or addressing sexually transmitted infections. When we talk about testing, when I started in 2001, we didn't have a rapid test, let alone a rapid test that you could buy at the pharmacy. So we live in such an exciting time. We need to capitalize on what we're doing well, do more of that, but also try some new things with the new tools that we have, and be willing to take that risk. What else? Oh, and because of my background, I assume I was elected co-chair. I was introduced as chair, but I'm co-chair with Angie Miller from AFC, who's here tonight as well. Co-chair of the Primary Prevention and Early Identification Committee on the Chicago Area HIV Integrated Services Council. And it's a dynamic group of people. We have a lot of work to do, but we're very committed to doing it. If you would like to join us, please do. My email is my name, danielp@howardbrown.org. Those of you in the TV land, please feel free and email me. Any information that I can provide tonight, I'm happy to do that, but more I want to be hearing from you, so I hope that I get that opportunity. Thank you.
Thanks, Daniel. I'm very humbled first by, being invited to sit up here with some of the people who trained me, like Marisol and Peter. So I'm grateful to be sitting here with them. I'm here to talk about linkage to care and retaining to care with the youth. My story is, I'm London Benton. 2005, I was diagnosed July 13th with not just HIV, but I was an AIDS patient. My T cells were 79. I had come to many doctors before being diagnosed, and I guess I put it out of my mind that I was HIV positive because they ran all type of tests, but I didn't know that I was supposed to tell them or to ask for an HIV test during that time, so I always thought that they were doing it, so that was the least thing I was worried about. But when I was diagnosed, like I said, my T cells were 79. The lowest they've ever been was 0. I'm happy to say that I'm undetectable now. And I'm excited about that, but linkage to care is 20,650 people, and retained in care is 13,767. So there's like 7,000 range of people or youth who are not in care or lost to care or lost out there without care. And I was one of those people. And mainly it's because if you come from a black family, and to say that I'm HIV positive or to say that I'm gay or I'm openly gay, you're put out. And so I was one of those youth who were put out because I was raised in a Pentecostal home. And so it was deemed that it was judgment of God. And so I was put out, so I wandered the streets for a while, went from house to house to house. So my thing was, what I looked like going into care if I didn't have a place to lay my head. So if I didn't have a place to sleep, I wasn't thinking about coming to a doctor's appointment. I wasn't trying to get in care. I wasn't trying to take no medicine. I was worried about where I was going to sleep the next night. And so I'm grateful for the steps that we've taken. And with Mark, I wish I would have met him years ago. Then maybe I would have been further along in my journey. So that's pretty much what I wanted to talk about, and I'm waiting on to hear what you have to ask us and to see where we can go from there and how we can help the community better.
Good evening, everyone. I'm Toyin Adeyemi, and I'm one of the physicians who's privileged to work at the Core Center. I've been seeing adults living with HIV since 1999 in this clinic, and I was asked to talk about viral suppression and keeping people suppressed once they actually get through the testing and bring board to clear with all the work that's been done by a lot of people in the community. And so as a clinician, when someone is sitting in front of me, and how do we get the numbers up of people who are virally suppressed? Now, at the Core Center, we have 5,500 individuals who we take care of here, which is about 1 in every 6 adults in the Chicago area living with HIV. And what I have to say is to get to viral suppression is teamwork. The medications have gotten a lot better over the last 14 years. 15 years I've been in practice, from refrigeration 3 times a day, multiple pills, to at least 3 regimens that are 1 pill once a day. However, medications only work when you take them. And there are lots of things that have to go into that. So I am a researcher, and we're all about getting people into clinical research and getting medications and looking at quality of life, but it is a teamwork. And the Core Center is one of the places that you actually have a whole group of people supporting. So in terms of how to get to viral suppression, obviously medications, but teamwork and communication, and open communication between you and your provider, your primary care provider, listening, and primary care providers. So I really want to approach this as to get to viral suppression from the individual living with HIV to the providers, and also from the system, and kind of how we can go from the patient out or from the system in. And I'll start from, from centers that take care of people living with HIV. The centers have to be welcoming, they have to be open, they have to be flexible, and they have to, and there are centers where people don't always feel comfortable because of the culture of the place, or what age group is more welcoming in an area, what gender and what ethnicity. So centers have to be open from the center level, have to be welcoming, flexible to people's schedules. The support staff, in terms of other people, apart from the healthcare provider, case management, mental health, chemical dependency, takes a teamwork. And then from the patient and the providers, listening in the two-way street. The providers don't tell you what to do. It's an open partnership. And the people that we've seen that do the best are people who have that partnership with their providers. Listen and communicate. If you have problems with your medications, talk about it. And providers have to be open to listen and say, well, while this regimen worked on the last 5 people, you, based on what your toxicities are, we need to do a better job and come up. But not taking medicines because you have side effects and just stopping completely is not the way to go. So in terms of the patient, and again, there's a lot we need to talk about in terms of getting viral suppression. And the challenges obviously still include, as our population is aging, we have more than 4 out of 10 of our patients are over the age of 50, and a significant proportion over the age of 60. We have to worry about things that come with aging, bone disease and diabetes and cancer, and some of the other co-infections like hepatitis. So again, I am privileged to have worked at the Core Center 15 years. A lot of places don't have the support that we do to get people through therapy, and people who are engaged and committed to the cause, getting patients in and making sure they stay in care. So again, it's teamwork. Medications are great, the providers could be excellent, but unless there's a team approach, both from the patient end and support within and without the Core Center and outside of the institution. So teamwork and communication.
Thank you, Doctor. Hi, my name is Mark Sellers, and I've been in the field since 1996. Started out with Emerald House, which was, at that time, it was a home for clients in end stage. We've came a long way since then. Worked my way up, it was grassroots, worked my way up. I'm now in the administrative field. What we do is the STI HIV division has 2 programs. A lot of people don't know about them. I want to talk briefly about those. HOPWA, well, Housing Opportunities for Persons with AIDS, is the HOPWA program. And the CDBG program, Community Development Block Grant, is the CDBG program. We get funded from HUD to the tune of $6 million for the HOPWA program. And for the CDBG program, we get about $300,000. Now, that sounds like a lot, but it's a drop in the bucket. And I want to say, housing is healthcare. Housing is healthcare. Housing is the foundation of HIV prevention, treatment, and care. You've heard London's story, Peter's story. Just think about that, people going through that without thinking about, wow, I'm going to get kicked out the next month. Where's the landlord? Landlord knocking on the door. You don't have housing. How are you going to deal with your medication regimen? How are you going to deal with food, nutrition, personal hygiene? Housing is a fundamental human right. And I want, if anybody walks away today, I want you to walk away with that. Housing is a fundamental, affordable housing is a fundamental human right. Thank you. And why is this important? Because housing is the greatest unmet need of persons living with HIV/AIDS. Clients benefit when you get into stable housing. You get to deal with your medication regimen. In turn, that reduces HIV transmission. It reduces CD4 cell counts go up. Your viral load goes down. So I'm getting the signal now, but I really got a lot more to say. If anybody wants to contact me, I can be reached at 312-747-5851. It's the Chicago Department of Public Health, and we can talk about housing. Thank you.
Good evening, everyone. My name is Ramon Garnhire, and I'm the Director of Government Relations at the AIDS Foundation of Chicago. I'll keep my comments very brief. I was asked to talk about some of the legal and policy barriers and also helps that can help make sure that we both identify people who are HIV positive and also make sure that they're linked into care. But I wanted to start off my comments with a quick question. By a show of hands, how many people in this room have heard about or know about the Affordable Care Act or Obamacare? Great, wonderful. The follow-up question, now how many of you know exactly how to enroll into the Affordable Care Act or what benefits are included in it? Exactly. That is the dilemma that we are currently in as a nation and as a state. Right now we are in an opportunity that is ripe for reducing new HIV infections because of the opportunity of the expansion of healthcare to almost 30 million Americans who were uninsured or underinsured. But unfortunately, we don't have yet the knowledge base, or we haven't put in place the systems to make sure those people are effectively enrolled into care and are stayed and linked into care. So I look forward to having that conversation with you tonight, so feel free to ask lots more questions about the Affordable Care Act.
Thank you so very much. Thank you for role modeling for what we're going to have coming up. It is an opportunity for you to express your perspective around HIV, around HIV services, and around the gaps. If you have a question that you need to direct to one of our panelists, feel free to do that. We're going to be using this microphone right here. Know that we are still streaming live on CAN TV. And if for some odd reason you do not want to be on camera, you can jot your comment down, and I'll be more than happy to read that comment. Or you may go to our email address and put the comment in, and that is Chicago Cais, CAHISC@gmail.com. And we need those comments no later than July 15th. So we're seeking your perspective. We want to hear from you regarding HIV services. We want to hear from you as it relates to prevention or care or housing or getting tested, staying on medications, things of that nature. We want that perspective because we are looking at priority setting, we're looking at allocations, and of course, we are looking at forming a comprehensive plan for the EMA in 2014. I'm going to ask, as you come up, that number one, be concise and share your comments or your questions. I'm also going to ask that you keep your comments to 2 minutes. And last but not least, as you make your comments, and we do want to hear the good, the bad, and the ugly, but what we don't want to do is to name any organizations, okay? So with that in mind, I'm going to open up this microphone right here. If you have a specific question, please direct it to any of our panelists, and or if it's a comment, feel free to make that comment. Know also that we're taking notes tonight, and I thank Michelle Champagne from Management Synergistics for doing that. So know that your information is being recorded.
Hello,
Yes.
my name is Derek Fox, and my question is for Nick. When you speak about the black minority being the highest of HIV positive people being tested, what strategy are you going to use now? You know, get high, get stupid, get AIDS, and not using protection, taking off the condom, and then you're passing out free condoms, and now we're about to legalize marijuana. What strategy are you going to use to reduce that? Something has to be done new, some new thoughts has to come about.
I think that's a all-encompassing question. From my perspective, I think what I'm hearing in your comment is, you know, how there are so many other social factors that influence people's health and behavior. So from my perspective, you know, I think it's important that we continue to monitor these behaviors and understand people's behaviors, and also understand how these behaviors are affecting people not only from getting HIV in the first place, so like behavioral interventions, but also understanding how these behaviors affect their ability to access care or
We do know
take
the
their
behaviors
medications.
already. We get high, we get AIDS. I'm HIV, and I'm of a black minority neighborhood, privatized neighborhood myself. You get high, you get AIDS, you get stupid. The condom doesn't work anymore, so we're going to have raw sex, and we're high and we're out of our minds. We've got to approach it in a different way. What I'm asking is, what are we going to approach it with differently to bring down those numbers of black minorities, me speaking for black people, having HIV in high numbers?
Any of our other panelists would like to pipe in? Thank you very much for your comments.
Yeah,
And
I think
your question.
that's a great question. I think it's very frustrating as an African American man to know that we are a minority in this country, but we're 50% of the infections. I think that we've been trying to push condoms on people, and that works for some people. For a lot of people, it doesn't work. I think that what we've learned over the last few years is that one of the most effective ways of preventing HIV transmission in our community is to make sure that our people know their HIV status, are engaged in care, get treatment, take the medications the way they're supposed to be taken, and get the support services they need. If a person who's HIV positive starts treatment and takes the medications right, there's a 96% reduction in that person's, that is a 96% chance that that person will not transmit HIV to their partners. So that's a strategy that we all need to embrace, including people living with HIV, in terms of not only it's just a good thing for us to take the medications, but it's a good thing for our sexual partners and for our community.
Very much. Thank you. Any additional comments? Any questions? Yes. We're live. We need you. Thank you. Thank you. Thank you.
I'm glad to be here, just listening. But what I heard from the young man, it sounds like there's an accountability type issue where we have to take responsibility of ourselves in order to minimize, eliminate some of these issues. That was just my thought.
Well, let me ask you something. What do you think about that idea of us being accountable, not just for our own health care, but for our partners and for our community?
Well, you said A, B, and C. You named some of the things that need to be done. So that's an accountability issue of each individual. Individually and collectively, everybody needs to be able to be a part of that. So like I said, I was listening, and some of the things that you were saying right away in my mind, it said, well, wow, that's accountability issue. So we all need to take responsibility of what's going on to start to minimize some of these issues.
Thank you very much. Thank you very much. Any additional comments? Yes, please.
Hello, my name is Carl Jenkins, and I'm on the Consumer Advisory Board here at the Core Center, and associate involved with the Austin Community Health Center. I'm HIV positive, and I'm 63 years old. My greatest concern is as I age, what system is in place to make sure that I keep my appointments, that I'm not lost to care? Because with aging comes other issues, and the loss of memory is one of them. And I'm very concerned about that. Right now, routinely, I get appointments, people call, but what happens? What do we have in place for senior services with individuals impacted with the virus?
What do you think should be in place?
Well, one, follow up through direct contact, visiting, home visiting. There needs to be support groups, particularly for seniors or those who are advanced age, because they have their own issues that they're dealing with. And they need that type of support so that they can maintain a healthy lifestyle.
Thank you so very much. I think we, Doctor, want to chime in, please.
Yes.
Thank you.
And Mr. Jenkins raises an excellent point about aging with, and I mentioned that when we were talking about some of the challenges. So with people taking medications and living long, healthy lives, we also have, regardless of viral suppression, other medical problems that come with aging, and we're starting to see that. And actually at the Core Center in the last 5 years, a lot of work that we're starting to look at and research is specifically looking at those issues with bone disease, heart disease, neurocognition, memory, things that happen. And so looking at screening and looking for memory dysfunction that may not be obvious initially. If someone comes in, when we look at our patients, actually at Core Center, among our adults over the age of 50, 80% of them are suppressed, 8 out of every 10. Regardless of other medical problems, high blood pressure, diabetes, heart failure, whole bunch of medications, cholesterol medicine, all of that, they're taking their medications and coming to appointments. It's not easy because they have a lot of other medical problems. But what we're trying to find out is, as people age and become a little more frail and have, what are the systems in place? How often is this happening? And what are the support services? And we do recognize, and one of the, we have right now like a center grant between Rush, UIC, and the Core Center, looking at disparities in neurocognition as people age with HIV, but also trying to get a better assessment of social support. A lot of our older adults live alone. A lot of them may not be engaged in social networking or groups. So like you brought up, we're trying to have meetings and quarterly seminars on healthy aging, because we know with our older adults, the HIV they got under control, 8 out of 10, and the other 2 probably just haven't started. I mean, they're taking their meds, but it's the other medical problems that are an issue. So trying to have, actually, we're engaging now with our non-HIV colleagues in geriatrics, in cardiology, in diabetes, to come over and do quarterly seminars on aging, healthy aging, and talk about diabetes, obesity management, things that are more pertinent, but also to figuring out the social support and housing, and especially if people live alone and don't have necessarily that social support, family support, what is in place as people start to age. And that's a big area that a lot of people are looking at that you bring up. Very excellent point.
Thank you very, very much. Great point. Thank you so much.
Yes, my name is Donnell, and I was had maybe 3. One of them, I'm not sure who will have to answer, but I was wondering, I was told about this prevention drug called Truvada, supposed to be a medication for people that's positive with AIDS as a prevention drug. But I never heard anything else about this particular drug. So, anyone have a comment about that? And as well, I wanted to know about, since I heard that it's an increase in the black community concerning people receiving positive diagnosis being HIV positive. So I was like, well, as there's outreach programs that, they start targeting the neighborhoods, as far as the black community neighborhoods, it's going to be more. I'm thinking that's, going towards the solution. If there's more in them neighborhoods, then it should be more outreach and targeting. Well, I've been seeing, involved in some of the testings, and I was seeing that, whatever it takes, they want a T-shirt or a sandwich or food, then that seemed like that worked.
Okay.
Get them to get tested, you got to offer people something.
All right.
And I just want to know if there's going to be more of that, some more like, the solution.
All right, I've heard, thank you very much. I've heard two questions. One question has to do with the medication, and I would like to ask a doctor to respond to that. And the other question I heard was around outreach, and how do we do outreach in the various neighborhoods so that people know about testing. And I think a couple of our panelists can address that.
Yes. So thank you for your question. So you mentioned Truvada, and Truvada is part of a component of one of the, actually a very strong backbone of a lot of the regimens that we use to treat and keep the virus suppressed in patients living with HIV. So Truvada is a component of many other medications used for treatment of people living with HIV. Now, more recently, there's information on Truvada used as PrEP, or pre-exposure prophylaxis, and that's where your point is. Using a part of, no, so we never use Truvada by itself in someone who has HIV. You know it needs to be combined with another regimen to get your virus fully suppressed. But there have been studies done, and it's approved and looked at for pre-exposure prophylaxis in terms of someone who is HIV negative taking Truvada as a way to prevent them getting infected if they were to be exposed to someone who was HIV positive sexually. And so Truvada is available as PrEP, and it's one of the things that the FDA has given us guidelines and CDC about how to offer it, because we're going to be talking about giving people medications to take, and they've looked at, can people need to take it daily, or can you use it, less than daily, or use it just before intercourse. The data is to be used daily. That's when it has the most effect. But then the question becomes, a whole bunch of issues in terms of monitoring, because when we use it as part of an HIV regimen, we are monitoring and checking the kidney function and having people in care. We're not going to be prescribing it for people who don't have HIV. And so in terms of who's going to prescribe it, who's going to monitor, definitely has efficacy in terms of preventing HIV. And now in the studies, when Truvada was used, it's very clear to know that in all the studies, everybody, the people who got Truvada or didn't, all got counseling. It was a whole bundle. They got tested for hepatitis B, hepatitis C. They got condoms. They got vaccinated. It's a whole comprehensive package. But everybody got the comprehensive package, which is what we do right now, and the people who did get Truvada had a much, much lower rate of HIV infection. So it is an effective strategy, but obviously in the bigger context, it has to be looked at about who's going to prescribe, who's going to follow up, what are the long-term side effects. You start someone at 18 or 19 on Truvada, and how long, if there's going to be issues with resistance. So there are issues that are being looked at. There are already practices that have setups about how to prescribe it and who to follow up, who's covering it. The Bureau is looking at that. So the infectious disease group here has brought it up with the Bureau. We have, it's still being looked at as a viable option, but it is something that is out there, and it is an option to prevent transmission.
All right, thank you very much. In response to the second part of the question around outreach and how you think about that, if you can respond to that, and maybe have it from a youth perspective too, would be helpful.
Okay, thank you. There are two issues really that I heard. One is outreach, and the other one is the aging issue. And some of these issues as they come up have a direct reflection in terms of the funding and how funding is provided by the CDC, and how the Prevention Planning Group and CAHIS decide how the allocation of funding is implemented through the city of Chicago. I don't know the epidemic, but the last time I looked, there is, in terms of the aging population, an increase in that area. And in terms of outreach, the CDC is focused more on targeted outreach. By that I mean you can't just go and test the population in any corner. It has to be specific to where the epidemic is at. For instance, on the South Side, among African American women, among African American men. And I could tell you specifically about one of the projects that we do have, which is Women HIV/AIDS Talk. That's basically a CDPH-funded project which focuses on women of color, specifically African American women on the South Side. And we provide HIV testing for a number of women on the South Side of Chicago, and we do identify positive women and we link them into care. But then again, speaks to highly targeted HIV testing, and that is what the CDC is willing to fund. They're not willing to really fund routine testing. They're just making the recommendation, do a routine test such as we do in our clinics and our hospital setting. And they're not funding that. They're funding highly targeted outreach testing, which addresses your question. And I'm assuming that maybe Cahiz can take a look at the epidemic here in Chicago and take a look at do we need to start funding the aging population here in Chicago? So.
The question that is coming has to do with, have we developed a slogan? How do we get people engaged as we're out there testing people? I don't know. I'll leave it to some creativity to happen around that, if you can mind. And then I'm going to ask for the outreach in terms of youth. Any perspective on that?
Outreach in terms of youth is to get to the clubs. A lot of them are in the clubs. A lot of them, like I said, are homeless. And so they're walking around Belmont, or they're walking around or living from house to house. And if they can get stationary and get a stationary point with housing, the outreach will help. But it still depends on them, and like the guy said, it's an accountability thing. If they don't want to come in to get tested, if they don't want to use the condom, you can give them condoms all day. Like the young man said, I have condoms galore and I pass them out, but it's not necessary that they use them, you know. And if they don't use them, then what are you going to do? You really can't do anything about it, but keep telling them, keep, you know, trying to hint that you can be tested, that you need to know your status, know who you're sleeping with, know your partner's status. But that's all you can really do, is try to tell them and hold them accountable. And giving them incentives is really not going to help, because they'll come in and get the free T-shirt, they'll come in and get the free food, but if they don't want to get tested because they don't want people to know, a lot of people, like I was talking a couple of years ago, I would come here and I would see different people that I knew from church or what have you, and they would have on these big glasses and these hoods over their head. And I'm like, well, you really don't have to do all that, because we got off at the same train stop. We walking into the same building. I'm going to get the same brown paper bag. So when we leave out, we could just go and take our medicine together and grab something to eat. But they don't want people to know who they are, so they try not to even come to get tested. And that's the majority of the thing. They don't want people to know. Yet they still want to have unprotected sex. And some of them want to do it, like it was a while ago, it was a group of kids who were looking for people who were HIV positive to infect them so that they can get it, so they could sit at home and get an SSI check, because they felt like $700 was better than a life.
All right. Perspectives.
I'd just
Yes,
like to
please.
add something.
Okay.
London brought up something that was really interesting about stationary youth. Just wanted to inform the audience that out of 21 HOPA agencies that we fund, only 2 concentrate on youth. 1, LGBT youth. That's disappointing. In the next funding cycle, and I'm calling out to the audience, we look for innovative programs such as youth. We don't have enough youth housing. And if we could do that, we probably could deal with some of the outreach issues. Thank you.
All right, thank you very much. Thank you.
So I've been asked to do a brief break in programming to announce a few sites that people should visit. So we're asking people to go on stepupgettested.com and check out the many testing sites. Also, we ask that you go to Text to Survive to find the nearest HIV testing site nearest you. We ask that you text Illinois plus the zip code, and that information is there. Actually, if you can go to HIV/STI hotline, that's 1-800-8-AIDS. We can also provide you with information there. That particular hotline is open 7 days a week. Also, we want to recognize our Chicago Public Health partner. If you want to visit us at Chi Public Health on Twitter or Facebook, we ask that you do that. Also, Step Up Get Tested is on Facebook and Twitter also. And then lastly, we ask that you support the Spread the Word scratch-off ticket that support many of the HIV/AIDS programming here in the state of Illinois. Thank you.
Welcome.
Hello, my name is Emery Bolden, and I was, first of all, want to address that one statement that the young man brought up about slogan. And there was a slogan that I have been a part of. I'm an outreach worker. I'm on, existing on 2 CAB boards, consumer advisory boards, and I'm an advocate of HIV and a consumer. And the slogan from Change My Story was developed a couple years ago. It's revised as to change the story, and it was widely popular from AFC. I'm sorry, not to mention agency, but anyway, that was where it was derived, and to reiterate that and to continue to follow up on that, that's where it's going to be done and continue to do. And I think that is key to helping people to not just get tested, but to stay in care, but to have a mind change on what they need to think about. Because I'm hearing a lot of the different things, and I see a lot of that in the community, that it's not important. It's not. They're afraid, and they're not sure that they want to, or they didn't want to be seen, like you said. We want to change that. It's not so much of a stigma to be known to get tested, because it's not something to be ashamed of.
All right. Change my story. Change the story. Thank you so very much. One more?
I have another question.
Oh, another question? Sure.
If two-part, I'm sorry. I'm also a person with have HIV that has Medicare and Medicaid right now, and I was told at one time that I'm safe as far as my insurance and everything, but this county care and this Affordable Care Act, I'm kind of wondering how this ties into my, not just my continuing care and getting medications and dealing with my continuous, and how to help other people as an advocate to help them to know what they need to do.
All right. Understanding some of what you asked for,
Great
Affordable
question.
Care
Great
Act
question.
and Medicaid. Yes.
So under the Obamacare or the Affordable Care Act, there are 2 major components that individuals can pull down coverage to health care from. The one is the one that you first talked about, is Medicaid. And so under the Supreme Court ruling back in June of last year, it said that states can opt to expand Medicaid, which basically means that any individual who makes under $16,000 a year now can get health care coverage. That's a game changer. Before, Medicaid was a categorical program, which meant that you had to be poor and something else. You had to be poor and disabled, poor and old, poor and pregnant, poor and dependent children. This is a game changer. It basically says the only requirement you have to meet is that you make under $16,000 a year and you get health care coverage. That's really critical and important for making sure that we continue to link people into care, because it's one thing to get diagnosed. It's another thing to say that now I have to take medications that cost $2,000 a month. That's really critical. So that's one way that individuals can access care through the Affordable Care Act. The other is what we call healthcare exchanges or marketplaces, and that's for individuals who make up to $40,000 a year. You can buy insurance. It's basically, the best way I like to describe it is, it's like orbits for healthcare. So you go in, you say, I'm 35 years old, I'm gay, I want healthcare insurance, and it spits out all these plans that you can qualify for. And based on your income, there'll be an income scale which the federal government would give you subsidies to help you buy healthcare insurance. And again, this is a new paradigm for the entire country. And I think that as we move forward, we have to do a better job of articulating what these benefits are for people in our communities and enrolling them. And so I look forward to partnering with everybody in this room and helping make sure that we can do that.
Great, thank you very much. I have a question that has come, and it says, can you discuss how resources or the lack of resources being allocated to reflect and address the disparities in the rates between YB, MSM, and other high-risk groups? So let's talk about resources, is what this is about, particularly as it relates to high-risk groups. Anyone want to tackle that one for 2 seconds and a half?
Well, yeah. We'll share this.
Absolutely.
So if I understand the question right, the person is asking disparities between resources, prevention dollars that are targeting high-risk Caucasian men and high-risk African-American men? Is that how-
YBMSM is what I see here.
Young, black MSMs. Are they comparing them to other groups, or?
Just discuss the resources and or the lack of resources being allocated to reflect and address the disparities in the rates between young black MSMs and other high-risk groups.
I think that the Centers for Disease Control, certainly the Chicago Department of Public Health, Illinois Department of Public Health, and CAHES recognize that this is a priority population. That being said, the city and the state receive a certain amount of dollars from the Centers for Disease Control to do HIV prevention. CDC has what they call high-impact prevention now, which kind of is a guide for how both health departments are told to use their dollars, their prevention dollars. I don't think that how we, as planners and how the health departments distribute those dollars, the cause of the disparities. I mean, that's my opinion. I think that, recognizing that that's a priority population, I mean, it's clear. Nick and other epidemiologists, when they present the data shows that young African-American men are more likely, out of all other people, to become HIV infected. And I think all of us are just doing the best we can with the resources that are available to us. And we advocate for more money, but, the United States right now, everybody hears about it all the time. Congress is always looking for ways to cut dollars, and that fight has been going on very vigorously for the last few years, 4 years, going on 5 years, and we all know why. So, until I think we break out of this logjam that the country is facing in terms of the economic climate and the political climate, we're going to continue to struggle with those populations because we simply don't have enough resources. It's not because people aren't doing their best, though.
Okay, all right, thank you. Anything to add to that, Daniel?
I mean, I'll just say that, I mean, the numbers are certainly clear. And I kind of feel like, you know, based on my experience working with clients and my experience living here in Chicago, there's kind of a perfect storm that we have. It's not just the fact that when background prevalence or the amount of HIV in a group of people starts to go up, that all of those people in that group are more at risk, although that's certainly a part of it. It has to do with access to services. Are there enough services in the places where these people live that are accessible, that are affirming of who they are and their identities? It has to do with the value of relationships. Are the relationships that men have with other men valued in our country and in our communities? It has to do with social determinants, jobs, housing, incarceration. And you know, what we have done in the past and what we will continue to do is look at the numbers and make sure that dollars follow the numbers, that small pie of dollars that there are. But this is an all hands on deck moment. And you know, the problem of HIV in Black America or Latina America or gay America is not one group's problem. It is all our problem. And we have to be in this together.
Thank you very much.
Good evening, everyone.
Good evening.
My name is Dominique Wilson, and I am here to say thank you for having this opportunity, and also try to see something that was already spoke about. Is trying to see how can myself and other youth be more a part of this fight. I think the gentleman that was just up here brought up some really great points of we need to be more honest about what's going on in our lives and really step up and really contribute to what's going on in our culture, not just with the health, but also with the violence and other things that are hindering us from succeeding. So pretty much, how can I help? How can we help so that we can actually get some more things done? So that's my question.
Thank you.
I think that at Cahese, for many years, HIV planning, which is a great opportunity for young people to get involved and to make a difference. We have not had a structure, I think, and schedule that really accommodates that. So I think that what Daniel and Hannah Anderson and others we have to do is we have to rethink when we have meetings. What do we need to do to make sure that we're having our meetings at times and places where young people will attend? We have to create an environment where young people feel comfortable and welcome, you know, whether that's mentoring or whatever, but we have to do something to make those opportunities available for you, because we have failed. In that area, we have failed. But I would encourage you to apply to become a member of Cahese if you have the time and the commitment to do that, and we would love to have you be a part of it.
Well, I would definitely do so, and also try to see what other avenues I can pursue, and other individuals that can pursue, because I know other youth that are impacted by it, and I know that they're willing to step up to be a part of this just as I am.
Well, when I joined the Chicago Department of Public Health, Hannah Anderson opened doors for me that I could never repay her for. So if you want to get involved with that, she's definitely somebody to link up to. But I remember when I sat on the board, I was the youngest in the room, and it was so intimidating. You know, as much as I was just gung-ho about being out there and ready to go, I was in a room full of people who had already run the race that I was trying to run. And so you have to really have a made-up mind and a fixed heart to know that this is what I want to do. And I've lived all over the country, but when I lived in Atlanta, they're so open about their sexuality as a city, but they're very closed about their status. And the CDC is there, but I've run into many people who don't mind waving the gay flag, but they're not going to tell you that they're positive. And they'll sleep with you. And they would prefer you not ask them, because if you ask them, they're upset with you, because now they have to tell you. And so it's like, don't ask, don't tell. And so if you want to get involved in the youth, do it, but make sure that's something you really want to do, and that you don't mind your face being all over the place. You don't mind being talked about. You don't mind being stigmatized, marginalized. You don't mind that. And if you okay with that, then I say do it. And if you're going to do it, do it. And do it. And don't be ashamed to do it.
All right, all right. Thank you very much. Thank you. Appreciate that. All right. I think I've got a couple more people. I know you have been, can I grab him and then you can come right after to hear your perspective around the services and HIV in Chicago. Yes.
Hello, my name's Andrew Espinosa. You'll have to excuse me, I'm a little shy. Just kidding, just kidding. You guys know me. I have been HIV positive since 1997. I am fortunate enough to have the love and support of many people. I take my medication every day, and HIV is not a part of my life, a part of my health. So that's good. Unfortunately, it's my job. So every day I have to face it. And a few things I want to point out. Number one is, yes, there is a stigma out there. And the stigma is the driving factor that's really hurting everyone. I work with routine HIV testing in Chicago, and now it is the recommendation for all doctors, for all physicians, for all caregivers that you see, that they should be offering everyone routine HIV tests. So if you're going out there and you see your doctor, you ask them for a test, and they will have to give one to you. We have to make people take some responsibility of their own health care because the doctors are not doing it on their own. There's too much stigma, and people are just don't want to talk about this. So that's the first thing. That routine testing is out there. It's covered by Medicare, Medicaid, Medicare, Affordable Care Act, private insurance. So you ask for an HIV test every time you see a doctor. That means if you're in the emergency room and you have a broken leg, you can ask for an HIV test. We're trying to drive this home to everyone. Second, if you have an STI, a sexually transmitted infection, there's a lot of people in Chicago that have those, and a lot of people seek treatment for that. And many of those doctors are not testing for HIV, which is a real shame. If you have an STI and you go see a doctor, again, ask for a test. So, so important. The last thing I want to say is about the geography of this, and the gentleman talked about this for a bit. If you go to aidsview.org, AIDSVU.org, you click on a map of Chicago, you can click on a map of your exact zip code, and you can find out how many people have HIV in your zip code. And I'm telling you, in Chicago, there are many places that have 3 to 9 times the national average of HIV in their zip code. So, sir, that's one way to find out what's happening in your neighborhood. And then people in their neighborhood have to realize that. The word has to spread about that. So people go out and get tested. It's so, so important to know that. The information's out there. We got to get the information out to people. So really, every time you see your doctor, you can ask for an HIV test. Don't be ashamed to do it, because unfortunately, there's still stigma out there, and people aren't doing that. The last thing I want to say, the geography thing, you can see the hot spots in Chicago. And let's not lie to ourselves. We can overlap maps of poverty, school dropout, unemployment, incarceration over all those maps, and they're about the same hot spots. So we're not going to be able to fix all the social determinants out there, but we have to really realize that what the facts are and that's out there. Let's be realistic about this, and please get tested. Thank you.
Thank you. Thank you very much. Thank you.
Again, I'm Carl Jenkins.
Welcome back.
One of the concerns is how we deal with, we talk about stigmas, but I do believe that the church has a great, needs to be helpful. Now, there are, in this epidemic with HIV in our communities, I do know that there are some great churches in Chicago that are embracing the call to help those individuals who are at risk and who are HIV positive. But it's far too little. When we develop slogans that it's okay to get tested, some kind of way we need the persecution of being, we are dealing with the issue of, I want to be welcome in my church. I want to know that God is still in my corner. But this message is not coming out. It's, you know, it's kind of crazy. And so you will hear, we have many churches in Chicago, so you'll hear different messages or no messages at all about HIV and those people who are impacted. I'm still hoping that community clinics and are outreaching with the churches or conventions of churches to help pass the message about getting tested. But I do believe that the clergy needs to come on board with a message of reconciliation and hope for people who are HIV impacted so that they don't feel condemned, at least not by God. Don't spread that message, okay? Because I do believe God loves everybody.
Yes.
But if you spread that message that you're impure or you're beyond reproach or you unsalvageable, people will react in the way people carry out their lives. And the church is our bastion for hope. We can never get away from, especially people of color. We can't get away from that. So I belong to a group of clergy-based and groups who are working around educating pastors around HIV, how to help people with HIV in our community and drive down the numbers. But that has to be a citywide approach. And we need the religious people of God to step forward and spread that message of hope and reconciliation.
Thank you so very much. Appreciate that. All right. Any other comments?
To that, I am a preacher's kid. And like I said, I grew up in a Pentecostal church. And so no matter what they preach, they'll say God can heal you from cancer, God can heal you from this, God can heal you from that. It's very rare that you hear a pastor say God can heal you from HIV/AIDS because they still deem it as judgment from God. They still feel like it belongs to the LGBT community and that if you caught it in a way that it was not pleasing to God, so that's why you caught it. So who knows if that'll ever change. You know, a lot of the preachers and the ministers have yet to be tested. So they can't, you know, they can't tell their parishioners to go get tested, and they're still sleeping with the parishioners and still not getting tested. And I know, you know.
Okay.
I will stop that right there. But, you know, if they're sleeping with their parishioners and they're not getting tested, they definitely wouldn't tell the parishioner to go get tested because now they know they caught it from the preacher.
All right.
And most of the time, the pastor is married himself, and he's still sleeping with other young men in the church, but he'll get up and preach about LGBT community and that how being gay is a sin and HIV is a judgment from God, but he's infected most of his church.
All right.
So he's not going to tell you to go get tested.
With that note.
He's not going to tell you to go out and use condoms because he don't want to use condoms. And he feel like if he used condoms, then it's not feeling good to him. Or if he used condoms, it's only because his wife is at home and he don't want to take back what you just gave him.
Thank you very much. Thank you very much for that comment. We appreciate it. Question, comment, your perspective on HIV services here in Chicago. Yes.
Hi, good evening. My name is Alexandra Arjona, and I'm a professional in the field. I just want to offer just a little insight because doing social services is the most challenging, most difficult thing I've ever done, but I do it with an open heart. And what I mean by that is that there's no way that I can possibly even think of asking someone to think of their health and make it a priority when they have so many things affecting them on a daily basis, like social issues, financial issues, emotional things, like holistic healing that needs to take place as far as therapy and just counseling. Because a lot of the times, if you don't feel good inside, there's no way that you can even think about feeling good outside. So if I could just even ask everyone to just think of it, with an open heart and go to work, go to your community, go to your family with an open heart. Because a lot of the times we can say, well, we can start here, we can start there, we could start, up there. But if we don't start within ourselves, it's never gonna ever work. Just because if no one feels love and no one feels motivated enough to want to live and have hope in their life, there's no way that anything could ever work, because everybody's gonna walk around with their own baggage. And who wants to keep on switching baggage? From the entry door, from the person that comes to the clinic, from the worker, from the internal aspect, from the external aspect, from the community. I mean, honestly, I really think that it's just about helping one another, honestly. Because if I'm walking to the bus stop and I see someone that is in need and I ignore that need, there's no way that I can say, oh, I care about you. Have you gone to the doctor? Have you gotten tested? Because I just ignored the fact that you need either some food, some money. I can't think of what I shouldn't give you. I should just really think of what I can do to help you. And so honestly, if we just even take that as just the starting point, eventually it'll reach to the top. As a professional, I really think that all the paperwork that is demanded on us is so unrealistic, honestly. It's about numbers, 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 and people are just not that recyclable. They're just not. Their life is too valuable for me to feel like I have to give them a certain time to feel better about their situation to come to the doctor or to go see a therapist or to even think of treatment. And just, I understand funding purposes, I understand documentation, but it's just really, really unrealistic and inhumane in my perspective. Just because everybody is different. If I do an intake on one person, it might be 20 minutes. If I do an intake on another person, it might be 4 hours. And it's so unrealistic, the amount of paperwork that you have to do to remain funded.
All right.
So,
Thank you. Thank you very much. Quick comment?
Yeah, I just want to thank you for your comments. In terms of the issues around reporting, I think that Washington, D.C., Health and Human Services has heard us on this issue. It's an issue that those of us who have the opportunity and privilege to speak to people in D.C. about the burden that providers have in terms of documenting things that just, keep them from really providing services to their patients. So Dr. Ron Valliseri, who's an associate director at HHS in the HIV/AIDS division, formed a group 2 years ago to look at the core indicators and looked at specifically looking at reducing the burden in terms of what providers on the prevention side, the mental health side, and the care side had to do. That obviously hasn't been fully implemented yet, and even if it happens in D.C., with no disrespect to my health department friends and colleagues, it also has to trickle down from the feds to the states and the cities and then to the providers.
Thank you very much. All right. This has been a wonderful opportunity by which we have listened to the community. We want to continue this for another few minutes. So you now have the mic.
Hi, my name is Luis Lira, and I just wanted to give some insight. The Core Center does have a youth program, so we target adolescents and young adults. And we do have targets, but we also work outside our targets, so we don't turn anyone down. And we're always looking for opportunities to do work in the community, so, get in touch with us. We do education, counseling, and testing. We do linkage to care. So how did I get in touch with you?
The program is called Chicago HIV Risk Reduction Partnership for Youth. And you can call the core center. I'm listed, my name is Luis Lira, I'm listed on their directory. I'm the coordinator for the program.
All right. Thank you very much. Thank you very much.
And I had two follow-ups on comments that were brought up by the audience. And one was with this site, the AIDS VU, as looking at prevalence, and kind of bottles into one of the points someone had raised earlier about what is the slogan, how do we get more people tested? And, now, with all everyone's aware of the information, and people say, oh, well, now it's just men who have sex with men. So when we talk about, heterosexuals and women of color, and they're like, okay, no, that's not getting all the press. And, the issue is when you start to look at testing and getting people tested, that kind of information, because a lot of times when you throw numbers at people and say 40,000 people are not aware and 20,000, it just doesn't seem real. It never seems real. When you're sitting, with your hairdresser and there's 10 women in the room, it's a great opportunity to have people, and it just seems like it's numbers and numbers and numbers. But if you can say, in this zip code, like you said, in this zip code in your area, a 5-block radius, 2 out of every 10 people are infected, it makes it more real. It makes you, and like you said, what the prevalence is. And people say, well, I only have one sexual partner. But if the prevalence in your community reaches a certain number, and people usually, most people date within a 3-block radius. I mean, it's especially in the inner city. And that's what happens. People date and people, there's concurrent relationships and there's coming back to your exes and breakups and makeups. I mean, that's how it is anywhere in the world. That's where it is in Hollywood. I like to say Hollywood, there's a lot of, everybody dates the same, all the Hollywood people are. So everyone, but again, once you get to a certain prevalence in your dating pool, then it doesn't matter. And so we talk to women, it's like, I only have one sexual partner. Well, it depends on where you are. It's not about how your practice is, so you have to tell people it's not, if you are sexually active, you're at risk. And that's all you need to say. You don't have to say how many times, who many people, if you're a sexual activity, and it has to do. So that kind of information, when you go into a community and actually give them numbers, 1 out of 10, 4 out of 10, then people are more likely to ask their partners about their status, and it becomes real. So that's a resource that we can use on a community level. And then the excellent point the lady made about all the paperwork, but knowing that, and you said that, it's not cookie cutter. So when I talked about being very flexible, not just about timing of hours and having morning hours and then people who work come later, but also knowing that every patient or anybody sitting in front of you, people are very different. We all are, and our personalities are, and they're never going to change because you're living with an HIV. So there are people who get a diagnosis and their personality has always been go-getter, tell me what I need to do, I'm done, done, done. Some people are like, show me what I need to do. Some people are like, tell me and I'll listen, and you're the doctor, you just tell me. Some people are like, challenging you at every stage and saying, okay, what if I don't do this? What's the downside? And everybody's different, and we need to have that approach to get people suppressed and not just say, this person, because some people are going to come in, get all the facts, do their own research, and be done. And some people it's going to take a year, some people it's going to take longer, and some people at every visit you need to go over and over the same information. And that's how we deal with life in general, and that's how we're going to deal with this, and everyone's different. So those 2 points were very excellent.
Wonderful. Good point. All right. As we begin to wrap up our town hall meeting here at the Core Center, Ms. Yah Simpson was running a little late, probably caught in the rain. But at this time, we'd like to hear from her. Of course, she is a community epidemiologist and the founder of TACS, which is the Association of Clinical Trial Services.
Thank
Ms.
you.
Simpson.
You are so nice. You are, okay, my job is to bring up the rear, so I'm going to bring it hard and fast, because that's how we like it. Ain't that true? So what we're trying to do here today, some of the conveners of this is Laura Branch from Gilead Sciences, and believe it or not, Eric Kapler from Brothers Health Collective, and myself, the community epidemiologist for TACS, even though I do keep another job. Ain't that right, Nick? So being that we are trying to make this a vision, what we wanted to do, we work with CAN TV. We want to give them a shout out because this is the first time ever we've we've done this live. No one has ever done this in the 18 years of the National HIV Testing Day. Now, how many of you all knew it's been 18 years? I looked it up. That's what epidemiologists do, right, Nick? So the thing that we know in the 18 years, and then we're talking about this live, we want our audience to make sure that they tune in to the Hot Live. A's Call In Live, where me and Eric do have a hosting there every third Wednesday, and we bring the science to the people. That's what TAX is about, and you all have tried to bring that science, but there's a couple of points that I have to make sure that we do cover with science, and that is we talk about the Step It Up, Get Tested. We have these wonderful campaigns, Take Charge, Take the Test. We're greater than AIDS, be the generation. There's a lot of campaigns out, but when we're talking about testing, we're talking about fourth-gen testing, ain't that right? When we talk about fourth-gen testing, we're talking about fourth-generation testing where we no longer have to worry about a false negative. We're going to make sure that we're getting 100% positives. What that means is not just antibody testing, but antigen testing. Well, I told you I was going to bring the science, right? So that's one of the biggest aspects of bringing the science. Another one, and we're also going to be moving to where we're not going to be using a Western blot in the near future. So for those of you that's been holding on to that, get ready for the funeral. It will be out of here. The other part, and that has to do a lot with having more routine testing, and that's the FOCUS program that you've been hearing about from Gilead Science. So those are the things that's been working in our neighborhood. Another aspect of science is condoms. Right here in the city of Chicago is the condom maker for the female condom, FC2, and not enough of us are using it. So women, men, we all need to bring out these female condoms and let that be part of our armamentarium of what we're trying to do is prevent a virus from transmitting from one person to another. The other you've heard a little bit more about, which is PrEP, and I know that was explained earlier, but there's things like microbicides, and I'm sure Jim Pickett would love that, because we all have booties, and let me be clear, men ain't the only ones having anal sex. I said it. So this is one of the aspects we talk about with microbicides and vaccines. And those kind of apparatuses have been happening. You've heard the Bangkok study, you've heard all the Thailand studies. These are the clinical trials that are proving to us that PrEP and prevention is working. Not maybe, not I hope, it is working. So that's part of the science. And the bottom one that I really want to talk about, and I heard you say a little bit of it, Dr. Adeyemi, is that community level interventions. You all, just because CDC don't fund sister, don't mean you shouldn't do it. Oh, y'all know what I'm talking about. That's the inside one. That has to do with evidence-based interventions. And what we're saying is just because we didn't get the funding to do the evidence-based interventions, and it said evidence, so we know it worked, doesn't mean we shouldn't do it. So that's what that means. We're going to do it on our own with no funding because community-level interventions have not been tried enough. And that is a science waiting to happen. So the HIV Prevention Trial Network and the 065 study, which I happen to be a part of, have 2 sites in D.C. and in Washington working on community-level interventions. And you all, we are a control site, so you better bring that study here next. If not, we're going to have some problems. But my point is that's a community-level intervention, and that's part of the science. So when we're saying bringing the science to the people, we have to deal with comorbidities, hepatitis B and C, and that's what Brothers Health Collective is working on when they're doing the testing. We have to talk about HPV, which is happening, one of the clinical trials are right here at the University of Illinois. And we have to talk about CMV, and I said it, that's cytomegalovirus virus. You all may not know it, but my physicians in the room do. We're seeing an increase in that, and we definitely need to talk about it as it relates to people who are positive. Of course, STIs, sexually transmitted infections, I'd be remiss to say, when we talk about, and people, I had a question to me, why are they not talking about black women? That's because black women are part of the problem and the solution. We're involved, even if you don't say our name, we're still there. When you talk about gonorrhea and chlamydia, we're the ones with the highest numbers, not black males. So it's not a his or hers, it's a us. And I think I heard that earlier. So being clear, my time is ran out, but I really want to make sure that I thank Brothers Health Collective, Laura Branch from Gilead Science, and of course, our CAN TV collaboratives. This is the first time they've ever done this, and they did this because we asked, and that's the only reason. Somebody had to be the first to ask them, and they responded to us. So you all get a big shout out for doing this live. Again, my name is Yah Simpson. I'm with TAX, the Association of Clinical Trial Services, and we bring the science to the people. Y'all ready?
Thank you very much, Jan. As we begin to close down, we're going to be closing with, unless I hear any other comments, any other perspectives, then I'm going to be asking Ann Carmack. And there she is, Core Foundation, on behalf of Step Up and Get Tested Coalition, for some closing remarks, next step. And then right after her, it's my privilege to bring to you Ms. Hannah Anderson, CDPH, on behalf of ICE.
Good evening. So I'm going to wrap this up. I'll make it quick. Almost 2 years ago, Peter McCoy came to me, Peter from the Core Center, and Leslie Craig from HHS Region 5, and they said, well, we're thinking about creating this citywide collaborative to promote testing, and so what do you think about that? And would you like to work on it? And I said, well, I don't know. Sounds interesting. I wasn't sure if we could pull it off. Usually people don't collaborate as easily in Chicago, or that hasn't been the history, but sorry, I will say that. And so that was a challenge, and it was something that I was interested in working on, and I said, yes, let's try it, let's do it. Last year was our first year. We had great success. We tested over 5,000 people. We found 28 positives, linked them to care, and this year we're going to do even better. We have more partners, more community agencies, and we want to keep building on that, and we want to keep the collaborative going. So Anthony, we did say we were going to talk next week about planning for next year. But I want to thank a lot of people in this room for their hard work. Anthony Galloway and Eddie Curris were the co-chairs this year, and they did an excellent job. And maybe somebody in this room would like to volunteer for that position. It's fun. It is a lot of hard work, but you'll have a lot of fun, and you'll meet a lot of people, and you'll be doing something really great for the entire city of Chicago. Thanks.
As Ms. Anderson comes forth, I just want to say thank you again for your attendance. We are indeed happy to hear your remarks. Thank you so much, panelists, for your insight into this. How can we say it other than thank you very, very much. We want to thank our sponsors, of course, Step Up, Get Tested Coalition. We want to thank the Chicago Department of Public Health, CAIS. We want to thank the Illinois Department of Public Health. Ms. Mildred Williamson is here. And we want to thank CAN TV for their live broadcast of this town hall meeting. With that, Ms. Anderson will close us out.
So again, I'm Hannah Anderson. I'm with the Chicago Department of Public Health. I'm one of the administrators there. I am also the governmental co-chair for a really cool and exciting planning group that's one of our key partners called CAIS, and that stands for, again, the Chicago Area HIV Integrated Services Council. I want to give a big and thank you so much for the Step Up, Get Tested Collaborative, over 30 partners. Laura's my mentor. I mean, we go back. I think that she is just a phenomenal woman. I just want to definitely say that. Laura Branch with Gilead. It was just great. When we were talking about a month ago or so, we were talking about the National HIV/AIDS Testing Day and the Step Up, Get Tested Collaborative and how you were going to do the group was doing a town hall meeting. I just thought that that was just a great opportunity for CAIS to definitely get involved. And I just also want to say for everyone out here, thank you for being here. Thanks for coming out in the rain. Yeah, thank you so much for coming too. You always close it. Whether you're in the beginning or end, you always come with it. And I thank you so much. Anthony, you were right. Anthony Galloway, this was awesome. And we have to keep on doing this. So if you are interested in being a part of CAIS, either as a member, we're going to do recruitment soon. So as a member or just as a guest or just want to come out or whatever it is, we invite you. All of our meetings are open to the public, and our full body meetings are the last Wednesday each and every month at the University Center. That's 525 South State Street. We usually begin at 9 o'clock. I'm going to try to see if I can get Peter to kind of change that to 9:30, and Daniel, you know. From 9 to 12 o'clock is completely open. We have presentations, HIV epi data information we talk about. We talk about all kinds of different things, housing, mental health services, just different things. Like we have focus groups, we have forums, and we had a social marketing campaign a couple years ago called Get Real, Get Care campaign, and London was a part of that, as well as many of our other CAHIS members. So we do a lot, and you don't have to be a member, so come join us. I'm Hannah Anderson. You can reach me at hannah.anderson@cityofchicago.org, or you can call me at 312-745-0537. All these folks know me. Come on, get tested.
Great, great, great.